Hello and welcome to tonight's Rural Doctors broadcast. I'm Jerry Gannon, thanks for your company. Tonight's program focuses on Aboriginal health. Once again this year, rather than having a panel in a studio in Perth, we went to some remote areas to talk to some of the people at the front line of providing services to Indigenous people. We'll bring you some information about the new Kimberley Renal Support Service and the Kimberley Standard Drug List, both designed to support GPs and other health professionals to deliver quality and culturally safe care. We'll also talk to Mark Tennant from the Centre for Rural and Remote Oral Health about Indigenous oral health, and we'll discuss the role GPs and all health professionals can play in identifying and managing foot problems to avoid unnecessary amputation. But first up tonight, we're in Broome, where the Kimberley Aboriginal Medical Service Council has set up the Kimberley Renal Support Service. This service expands on the work of the Satellite Dialysis Centre to provide patient support, promote early intervention and educate clients and health professionals to better plan for and manage renal disease in the Kimberley.
Well, the Kimberley Renal Support Service has been the product of quite a number of years of work. It came into being because it became obvious some years ago that there was an enormous burden of chronic kidney disease in the Kimberley, and that we had this fantastic dialysis unit, which we're very proud of, and we think we do a good job. But it's band-aiding. We're treating people when the disease is rampant and there's nothing else we can do. And really, it doesn't manage their condition. It doesn't fix it. It just keeps them alive for an extended period of time, but it doesn't take the condition away. We want to actually be involved with primary prevention and enable people in the primary care settings to have the tools to be able to get out and educate their clientele in ways that will, or strategies to prevent getting the disease at all. And so that's where it started, big ideas, thinking, that this is way out there. There's sort of nothing exactly like this anywhere else. Business cases and resubmissions of business cases and resubmissions of business cases, and a lot of being squeaky wheels. And the government has very kindly funded us to run a support service. And so as of the last few months, the Kimberley Renal Support Service exists outside our minds. It actually really does exist. It's run and managed by the Kimberley Aboriginal Medical Service Council. We have a manager and a fantastic team. We've got a nephrologist that visits every 4 to 6 weeks. We have a chronic kidney disease nurse. We have peritoneal dialysis nurses. We have educators. We have people that are doing data entry and working on getting our chronic kidney disease database up to speed so that it's a functional instrument. We've got doctor, as in me, and we've got another doctor that's just started as well, which is fantastic. We have some extra assistants, and we have health workers as well. So we've got the makings now of a great team.
My role is pre-dialysis coordinator, so I look after the people who are in end-stage kidney disease. Within the CRIS team we have a PD educating nurse and a renal educator. She travels through the Kimberley, she books wax sites at hospitals, community health centres, and her role is to keep returning to the same sites, so 4 times a year to Derby, Fitzroy and all the places in between. Kununurra, Halls Creek, so that covers registered nurses, enrolled nurses, Aboriginal health workers and doctors working at these sites.
The idea is that we'll provide support to primary care to educate their clientele in terms of primary prevention, so we've developed some resources that we make available to primary care facilities. We go and do education in primary care facilities about the importance of chronic kidney disease or picking up kidney disease at all, and screening for it, why you need to screen for it, how you screen for it, what to do if you get positive results, who do you talk to, what happens. So that's sort of supporting primary care. We're not here to do the primary care provider's job. We're here to support and provide resources as we're able. In terms of secondary prevention, once a patient is identified as having a kidney problem, then one of the services that we provide is a resource for the doctors to contact us for information if they need information, or they want to access some medication, they're not sure how to access it. Those sorts of questions, we provide that resource. We go out and meet with the family themselves, with the patient, with their family, about the different options available. Maybe bag dialysis, maybe machine dialysis, maybe home dialysis, all different options, so we can talk to people about what their choices might be and which way they might like to go.
The basic choices, depending on their health and age and location, whether they have electricity and good water, good housing, sanitation, peritoneal dialysis, hemodialysis, which means leaving their family, which is not always a good option. No treatment or palliative is an option that people can pass in and out of. Initially they might say no treatment. As they get sicker, they might think, no, I'd like to engage. I might train someone who then goes on for peritoneal dialysis. They might have an infection, become unwell, want to come home, so then they will come back to a palliative option. So people pass in and out of each treatment option.
So to summarise, we want to identify the kidney disease early. We want to then manage the kidney disease as we pick it up. We want to plan for future therapy options. We want to be able to initiate those therapy options at a time that is optimal to the patient's well-being. That may involve getting vascular access in a timely manner instead of as an emergency. And we want to prevent intensive care RFDS type transfers where people end up in intensive care in Royal Perth or other hospitals, sick for some weeks, needing emergency dialysis, and it all is not ideal. We know the outcomes in that situation are much worse than if we plan therapy and we do it electively and the patient has their head around the therapy that they're going to be provided with and it's not strange to them.
People take a long time to come to grips with kidney disease. It is a silent killer. So the first they hear of it often, until we have better screening in place, is a doctor's telling them their kidneys are very sick. So that can take up to a year to accept, and these people often don't have that time. So we build a rapport with family, visit as often as we can, get them really comfortable about talking about choices.
It takes some getting used to that you're going to be tied to a machine or regularly, or you're going to have to put bags of fluid into your abdomen 4 or 5 times a day. And if a patient is presented with that scenario suddenly, it's hard to be compliant because they don't understand it. It's strange to them. That hasn't been brought up with them before. So that's what we want to prevent. So we work very hard to, from now, identify kidney disease early and manage it all the way through from the beginning to the end, and hopefully prevent people ending up on dialysis. The idea is with optimal management, if we pick the disease up earlier, we can prevent people progressing to the point where they need to have renal replacement therapy. When I first came up here quite some years ago, we were transferring 5 or 6, sometimes more patients a year down to Perth, intubated, ventilated. First time we knew they had kidney disease. Even if we did know about it, we hadn't known about it long, and there'd been no follow-up, no medication taking. So it was emergency management of a crisis situation. And now we are lucky if we have one of those a year, and we usually know about that person's kidney disease, and there's usually been a reason why they suddenly get sick and have to be transferred. Maybe got a chest infection which tipped them over the edge, for example. It's not very rarely now are they not known about, have they not had some chance to have some input into their disease process earlier than suddenly, this person's got end-stage kidney disease. And usually they've had, 98% of the time they will have had education, their families will have had education, and they will know what their options are. We're doing an education session via video link for all the doctors and any other interested people that want to come, specifically on renal education every Thursday morning from 8 till 9 o'clock. We need to know if you want to join us because we need to set it up with the video conferencing people to dial into your location. But if you want to join us, it doesn't matter where you are, you can join us from 8 o'clock till 9 o'clock on Thursday mornings. You'll get renal education. You're not going to get the latest in surgical techniques in abdominal surgery or whatever. It's going to be renally focused. So it's quite a different scenario now. People are more interested in kidney disease. It's more in the forefront of people's mind. They're more likely to screen for it. They're more likely to check for it. And when they do check for it, they're more likely to seek advice on how to manage it than they were, say, 5 or 6 years ago when it wasn't in people's faces, can I put it.
Keep it at primary health stage where there is a support. Please screen for urines and bloods so that we pick up the early kidney disease. The markers are diabetes, high blood pressure, and early childhood infections. People don't realise that's the precursor to kidney disease. And staff often aren't renally trained, they're generally trained, so they need that reminder constantly. There's a high turnover of nursing staff and doctors, so we need to keep going back and back with the same message.
One of our jobs is to be a squeaky wheel to the people on the ground. Don't forget kidney disease. Look for it, chase it up, follow it up. And I think anecdotally at least at this point, we know the RFDS transfers for this particular problem are down, and we know that people are more likely to have been spoken to and to have some sort of understanding of their disease long before they end up being put on renal replacement therapy or offered renal replacement therapy. So we're very proud of the service that we're starting. It's in its infancy. We think it's a good idea. We see some early changes that are very promising. We hope that we'll be able to prove that with figures in the not too distant future, and we hope that places elsewhere in Australia will want to copy this and provide a multidisciplinary service that is available for all people as a resource to the primary care providers and the secondary care providers and the families and anyone else who's interested.
Our thanks to Sherelle Fitzclarence and all the Kimberley Renal Support Service team. There's a lot of talk at the moment about oral health as a marker of socioeconomic disadvantage. Nowhere is this clearer than in the oral health of many Indigenous Australians. There's a growing understanding of where oral health fits into the chronic disease jigsaw and the relationship between poor oral health, diabetes, chronic infection and vascular disease. We spoke to Mark Tennant from the Centre for Rural and Remote Oral Health about what role the GP can play in promoting the oral hygiene of Indigenous people.
Australia overall is a relatively lucky country. It's a vast proportion of the country has access to fluoridated water and things. However, the distribution of that quality is not even. And in fact, I don't think I'm telling any of the viewers anything new, but rural and remote Australia has some desperately difficult situations with the dental health of people. In fact, the week before last we were out in Warburton and frankly there was some situations of dental health there that, my father would have been horrified to see as a dentist, let alone a generation later. So, the situation is really hard, and it's around a whole suite of things, and not a surprise for anyone. It's the suite of socioeconomic deprivation factors again. Diet, high sugar consumption, acid, Coca-Cola and those sorts of fizzy drinks and things. They are certainly upward drivers of the dental decay problem. And then you couple that with the issues of diabetes and its effect on capillaries, and not just retinal or ankle or leg capillaries, but capillaries in your gums of your teeth, and the gum disease you get out of that is quite significant as well. So the situation in rural and remote Australia is dire, would be my view of the dental health of people, particularly Aboriginal people. And in fact, we're just reading about it in the paper quite recently with the Commonwealth Government. It's quite a clear marker of socioeconomic deprivation. I actually, it's more than a marker, because it's actually that deprivation is driving it, and the graphs around the rates of holes in teeth, let's say, is just this lovely linear graph related to, CEFA or socioeconomic deprivation. So, and that's an internationally accepted phenomenon. It's not unique to Australia. But the thing that's interesting about it is that in countries poorer than Australia, where you don't have access to the other driver factors, sugar, then you don't see the disease burden you see. So we have a magnification of that socioeconomic driver because we're adding on top a disease pusher in the sense of adding sugar to people's diets dramatically, and I mean very significantly. The average consumption of sugar for an Australian is about 55 kilos a year. A kilo a week we consume in sugar. And that's been the same since the 50s. We actually haven't made an improvement on that. The reality is our grandparents ate it as 2 or 3 teaspoons in their tea, and it was overt, obvious sugar that they were consuming. These days the sugar consumption we have is hidden in burgers, chips, whatever. So our sugar consumption actually hasn't gone down. And you've got the secondary effect there is then you're driving up the diabetes problem as well. And it all just comes together in that cluster of problems that you associate with socioeconomic deprivation. It's like the tsunami, and I recognise I'm not driven by dental health. I recognise that tsunami is making such a negative impact on the greater health problems of people. And I just add a little bit of dental there too. It's no different to anything else. It's just the same story of letting communities down. The number one bang for buck that health practitioners can make is around toothpaste. That is the number. You don't have no special skills needed. You don't need nothing, but it has fluoride in it. So if I had one message I was to get to practitioners, doctors, nurses, I don't mind, council workers, anyone, is drive down the toothpaste journey. So in other words, get your community members using toothpaste. Now I'm quite clear there. I'm not saying toothbrush. Frankly, I don't care, I don't care if you use your finger, but toothpaste. If you want to use a brush, thank you, do that. But toothpaste will make a significant difference relatively rapidly. And we know that. The history of fluoridation in water. Originally we thought that fluoride affected your teeth from the blood circulation outward. The reality now, we understand it's actually a superficial topical effect. So, it's not that you need to swallow the toothpaste, you just need to get it over your teeth, right? So, toothpaste. Across Australia, toothpaste is mandated to have about 1,000 parts per million fluoride in it, so perfect. So that's unequivocally the best thing you can do for bang for buck. Get some toothpaste. On the actual treatment, doctors face dental problems. Patients rock up with pain, toothache, swelling, etc. Very hard for a doc to actually provide endpoint care. So the second message I give is make friends with your local dentists. Find them. Now that's, for someone who lives in the city, that's bloody simple, but for people in the Kimberley, that's hard. There ain't many dentists around. But find them and make a connection. For government dental services, 9313 0555. Ring up and ask where your local dentist is and find them. So make a connection with your local dentist so you can make a pathway when they come. Keep a little list. Your worst problem patients for dental care, keep a list. So when the dentist is coming your way, you give them the priority list and you tell them what you want done. So prioritise problems. Because, in remote areas, dentists usually are sort of on an itinerant. They only come for a small amount of time. And it's usually the people who shout loudest who see them. It's not the people who need the care. So you give them the priorities. Be active in that. In addressing immediate problems like swelling and pus and abscesses and all those things, it's an infective condition. We are talking antibiotics and painkillers. And, you know, if people want advice, talk to a dentist, ring one up and ask about it, what protocol you should apply. But it's an infective condition, it's pus, it's the normal sort of process of addressing that. That is not going to be the end point solution. Let's be clear, they need dental care, but it's a tide-over process. And that's about where I would put the ceiling on what I'd recommend docs do. Be active in prevention, be clear in having a connection to dentists, have a priority for your patients when the dentist comes, and address pus and infection. So they're my sort of 4 fundamental messages I'd pass on. I used to be a person who believed in, you know, implants, bridges, crowns, and, you know, the full kahuna. And the reality these days, I think, is you have to meet the patient's expectations. And often with dental care, their expectations are moderated by their environment, and all of us do it. I frankly moderate my own healthcare from my own environment. So one has to be empathetic to the position that your patient has. However, you know, I think most clinicians have a very simple belief about pus and pain. To put it bluntly, no person should suffer pain, and no person should suffer from the issues of having pus hanging around. And I think that's a good, you know, that's the flaw in my life, and it's the flaw in what we talk about in clinical care. When people come to the clinical services we provide, and, you know, there are places like Roebourne, Walloona, Warburton, Geraldton, a few others, AMSs I'm talking about. When people come there, they're clearly not limited to the care they can have, but in those situations, the care is basic primary dental health care. If a person is after a crown or a bridge or something more expansive than that, then we'll give direction and pathways to get that care. But at the core base site, we're about primary health care, and I think that's what people want. People don't want to be walking around in pain, and people don't want to be walking around with pus hanging around. So I think that's how care is sort of stratified in dental. I think it's very much similar to the general health system. You know, we have a primary healthcare system, secondary and tertiary to follow through on that. Clearly, if people come in and they've got black holes everywhere, then be proactive before the pus is there. Let's get going, you know, because you can, when the dentist comes through your community, you've got them on the list. So, you know, be proactive. But I think that's probably the limit of what I'd recommend. To actually look in someone's mouth and make nuanced decisions is quite a diagnostic skill, and I don't, that's not fair to add that burden to docs, nurses or whatever. You know, let's keep it simple. In oral health, we basically have fundamentally 3 major conditions that we're concerned with. There are a lot of other peripheral conditions that are rarities, but there's 3 fundamental conditions. Number 1, dental decay. And dental decay is a disease fundamentally where your teeth are dissolved by acid. And that acid can come directly from sucking on lemons or whatever, or it can come indirectly via feeding bacteria. And therefore you need bacteria and you need to feed them. So that's why the idea is about plaque. It's basically a bunch of bacteria, and sugar, because it feeds bacteria. So the idea around dental caries is to break that cycle up. Break up either the plaque, knock off the bacteria in some way with a brush, break up the sugar part of the cycle, stop eating the stuff, break up the tooth, in other words, reinforce the tooth so it's not affected by acid. That's the fluoride process. So they're the 3 fundamentals around dental decay. Second disease we worry about is periodontal disease, gum disease. Getting long in the tooth, whatever you'd like to call it, and that's a That's a disease basically where the teeth, the holding of teeth into the bone is reduced over time. And the driver of that, again, bacteria. But we now understand there's a very significant driver of the immunological systems of the host, the patient. So there are some people in our community who are destined for periodontal disease. No matter how hard you fight back, they're going to get it because of the genetics of the problem. So we now understand a lot more about that. We also understand that the driver there is also around capillary size and shape, back to the diabetes problem. So we're all in this big cycle of trouble, you know. And the third condition that I want to talk about is oral cancer. And in dental schools, we don't talk much about that because in the context of a large population like Australia, it's not a common condition. However, in rural and remote communities, it is more extensive, more of a problem. So if there's one simple additional diagnostic thing that clinicians would like to do would be grab a piece of gauze, grab people's tongue, pull it out of their mouth and look at the sides of their tongue. If you see anything that worries you, seek help. Things that are clearly ulcers or nodules and lumps, please make contact. Oral cancer, particularly tongue cancer, has a very significant mortality rate, and it's really important that action's taken. And it's more common in rural and remote areas and indigenous people. So please, if you get an opportunity, do that. So the three conditions we really talk about: caries, periodontal disease, and oral cancer. And again, the drivers are the same drivers we talk about with all other, cardiovascular disease, diabetes, the whole suite. It's the same story. When patients are talking to you, look at their teeth, and if you can take 1 minute to grab their tongue and pull it out and have a look, that would be the limit of what I'd ask clinicians to do, really. In a number of places where we operate dental clinics embedded in Aboriginal medical services, we've seen doctors start to think about adding some sort of check to their checklists that they hold and build themselves for various checks on patients as they come in. I would absolutely support that, and if anyone ever wanted some advice on how to do that, please, my contact details will be at the end of this presentation, so feel free to make contact and we would assist you with what you can add and a few photographs and things that can help you learn that process of checking someone's mouth easily. Very supportive of the ideas of docs making it part of their normal daily business to be part of oral health. If on the bottom of that checklist was, have we made sure that we've given away a thing of toothpaste at the same time, we'd be cheering even more in that process. So yeah, very supportive of that idea of adding to checklists like that. Be good.
A big thank you to Mark Tennant for once again joining us on the programme. And if you'd like more information or resources or help in creating an oral health checklist for your practice, you can email Mark and his team at mark@crroh.uwa.edu.au. Now, the stocking management and dispensing of drugs can be a logistical problem under the best of circumstances. Maintaining the supply of appropriate medications in remote parts of Australia, in clinics with limited staff and often with high staff turnover, represents a significant hurdle to providing quality care to people in remote areas. To help alleviate this problem, the Kimberley Aboriginal Medical Service Council teamed up with the Western Australian Country Health Service to develop a standard drug list for use at all clinics and hospitals across the Kimberley. We spoke to Karina Pesich from CAMS and Vicky Archie at Derby Aboriginal Health Service and asked them about the need for the drug list and how it was implemented.
The Kimberley Standard Drug List was initially established to try and rationalise drug use in the Kimberley. It was found that with the onset of Section 100 and a lot of our remote clinics being able to have access to medicines, both on the Section 100 scheme, so they get free medicines on the PBS, as well as access to medicines that are not listed on the PBS. There were found to be emerging issues around medication management and stock control and responsibilities around dispensing and issuing of medicines. So I guess the list came about to try and rationalise drug use. Essentially what happens is the clinic has to order the drugs from the retail pharmacy, which is based in town. They need to transport the drugs to the clinic, and then it's the clinic's responsibility for managing the drugs. So managing order, managing how much is being ordered, managing what's sitting on the shelf potentially going out of date, and managing drug usage as well. And with high staff turnover and with high patient turnover, this can be quite a challenge to do. So by limiting the number of drugs that are kept in the clinic, instead of having a whole bunch of drugs that essentially do the same thing in 3 or 4 different strengths, for example, the ACE inhibitors, I think there's about 8 or 9, maybe more on the market, that all come in a variety of different strengths, and lots of doctors will have favourites that they like to prescribe, and if you had to keep every single drug that every single doctor wanted to prescribe, this could potentially be a logistical nightmare in terms of stock control and usage, and there's obviously more potential for dispensing errors to occur as well if there's a greater selection of drugs to choose from at the dispensing process. So a whole bunch of very clever people got together in, I think, around 2004, 2005, came up with the idea, had lots of consultations, lots of review meetings with specialists and clinicians working in the Kimberley region, and eventually the first list was put together in November 2005 based on established regional prescribing habits already in the Kimberley, and also taking into account drugs which were listed on the PBS and the indications, evidence-based medicine and so forth. When we first put the KSDL out there, there was lots of promotion around it. There was a road show. The pharmacists went around and promoted it around to all the different clinics. There were posters set up, there were pamphlets set up, there was education set up with new doctors. We've got 2 pharmacists on board now at CAMS, and the idea is that we try and nab all the doctors when they first have their orientation to actually sit down with them initially and give them a bit of a spiel about the KSDL so that they're aware how it works, what the policy is around prescribing medicines that are not on the list. I mean, the list is really a guideline as to what medicines are routinely available in the Kimberley, regardless of whether a patient travels between a CAMS clinic or a wax clinic or a hospital. All our prescribers are aware of it, but it's by no means an exhaustive list from what doctors can only prescribe from. It doesn't meet the needs of every individual situation for every individual patient. So if they do want to prescribe something that's not on the list, our policy is to try and encourage them to fill in an appropriate form advising the review committee of the drug that they have prescribed and the reasons for prescribing it and why a drug on the list was not appropriate. So all the local doctors, regardless of whether they work in a government clinic or whether they work in a CAMS clinic, they're aware of this because this has been a joint partnership agreement between CAMS and WAX. And we're very lucky in that we do have a really good arrangement and partnership agreement in not only formulating the Kimberley Standard Drug List, but also we've got supportive quality use of medicines and therapeutic guidelines, which also implement drugs that are used on the Kimberley Standard Drug List. So the Kimberley protocols, for example, are again a joint initiative of WAX and the CAMS sector, and they're basically guidelines that are useful for doctors as well as nurses and Aboriginal health workers to have an understanding of how chronic diseases and conditions are diagnosed and managed and treated in the Kimberley, and obviously in the therapeutic guideline recommendations, the drugs that are used in the chronic disease protocols reflect those that are used in the Kimberley Standard Drug List. We've recently just had quite a lot of interest from the Pilbara region as well, who are wanting to get a list set up in the Pilbara also. So our last review meeting, we had input from the Pilbara also, and it's quite clear that a lot of these medication issues are common to other areas as well, not just the Kimberley. What is often the scenario in remote health services is you've got a hodgepodge of people coming in for short-term employment contracts who usually sort of get thrown the medication management task on top of all the other multitude of things that they have to do. And often things like stock control and dispensing probably don't get done anywhere near as efficiently as they potentially could do if there was just one sole person in charge of managing the drug room. And I guess CAMS has recognised that, and as a result we felt the need to be able to specifically train up people so that they can have the specific skills and knowledge that's required to manage drugs as well as dispense and issue drugs. So we came up with the idea of doing some pharmacy assistant training because it was recognised that there isn't any nationally accredited course or qualification available to support people working in an AMS environment. So we basically sort of created our own ad hoc generic training package, which changes all the time and develops all the time from feedback that we get. And it's very loosely structured. But it's working really well, and it's very successful.
The training that I've been involved in since employment with DARS has actually been a pharmacy assistant training through CAMS, the Kimberley Aboriginal Medical School in Broome. So that was a six months program that I was involved in. So I've been doing that training while employed.
There's no funding available to run the course and to run the training. It's been extremely beneficial that our individual affiliated AMSs have recognised the need and the benefits of this specific training, and they've taken it on board to fund the participants to travel to Broome, so they meet the costs of all the travel, accommodation and travel allowances that go with travel and training, and that's a huge factor in itself. Demonstrates how worthy and how beneficial that the AMSs see this training to be, and it has been very successful in our big town clinics.
A lot of the information I have learnt through the training, but it's also I've gained a lot of information and knowledge of medications actually as a hands-on within the clinic.
And a lot of it is just knowing patient names, knowing where to order drugs, knowing how to interact with new staff members and promote things like the Kimberley Standard Drug List and other quality use of medicines programs that are going on. And it's really important for new staff members to be able to identify with one single person to be in charge of the medicines and to be able to know, if they've got any questions around medicines, that one individual person is likely to be able to answer that, whether it be whether a Webster pack has been ordered or whether a drug's in stock or whether something's on the Kimberley Standard Drug List or how they go about ordering a particular drug. It's hugely beneficial.
I've found myself to be beneficial within the clinic to my staff colleagues in assisting the doctors who come on board. Also having that one-to-one benefits of informing and educating our clients who come into the clinic, and just giving them that additional medication information on quality use of medications, appropriate and safe ways of using medications, side effects, and also one of our aims is to also extend on the information and knowledge that I've gained by actually taking out to the community.
So with the supply of the medication, it's hoped that the appropriate education goes with it as well. Obviously, the limitations in remote healthcare service is that a lot of the times medicines are getting dispensed in Webster packs. So clients literally just see the tablets. They don't actually see the packaging. So if they see that their tablet used to be, they used to have 3 white tablets and a pink tablet, and all of a sudden it's changed to 2 tablets and 2 green tablets, alarm bells will start to ring and they could potentially think that they're getting the wrong medicines. So it's important to provide the education at the time of supply wherever possible. The major advantages from a stock control point of view are you're only ordering and keeping a select number of drugs, so there's better stock management available with that. As prescribing physicians, you get more familiar with a select number of drugs and less time is spent sort of managing and trying to work out what other drugs are going on. And from a dispensing point of view, our health workers and nurses, pharmacists and doctors, whoever's doing the dispensing, there's the likelihood that less dispensing errors are likely to occur because you're dispensing routinely the same drugs, the same strengths over and over again. But the major advantage is to our patients, obviously. So our patients are a largely nomadic population, and if they are moving from clinic to clinic, it's hoped that if they are on a Kimberley Standard Drug List and they're usually a patient of, you know, a wax clinic in the East Kimberley and they happen to be travelling to the West Kimberley and visit a CAMS clinic, chances are if they're on a Kimberley Standard Drug List and they turn up at a clinic that is not their usual health service, and they don't have their medications for them for whatever reason, those medicines can be easily accessed.
There's lots of meetings that are held throughout the Kimberley. You also get people who travel in sorry time or for funerals. Quite often they'll be come from another clinic where they haven't got, they don't bring their medications. So then they come and present to DARS. The doctors will, there's a process that we have to go through, protocol that we have to keep in the client release of information from the other clinic, so that happens. Then the doctors will go through their medication list, and whatever we've got, we are able to dispense.
And the other advantage, of course, as well, is that our clients get familiar with the drugs that they're being prescribed, so they know that if they've got diabetes and another family member has diabetes and they're on the same medicines, I guess that instills more of a confidence in the medication that they're being prescribed, and there's not sort of the notion that somebody else's medicine is better than theirs, or, you know, causing different effects to what's happening to them as well. So it's a win-win for everyone, really.
Thank you to everyone at Derby Aboriginal Health Service for allowing us to come in and disrupt the clinic. And CAMS would like to acknowledge the Rural and Remote Pharmacy Workforce Development Programme run by the Pharmacy Guild and funded by the Department of Health and Ageing for helping to fund positions to implement the Kimberley Drug List. Now, some recent research has shown that for some age cohorts, Indigenous people are more than 40 times more likely to have legs amputated as a result of vascular and nerve problems of the lower limb. These high rates of amputation are linked to chronic disease, including diabetes and other vascular conditions, coupled with a high risk of injury through environmental factors. The loss of a limb has serious implications socially, economically and culturally. We spoke to Deborah Schoen, a podiatrist from Royal Perth Hospital, and Leslie Newcomb, a podiatrist working in the Kimberley, about the role all health professionals can play in the early diagnosis and referral of problems that could result in the loss of a limb.
A very large percentage of foot problems in the Kimberley are related to having diabetes and the complications that go along with long-standing diabetes, such as loss of peripheral circulation or reduction in peripheral circulation, reduction in nerve function, which then go on to create their own problems because the person really doesn't have much sensation left, so they tend not to take care of their feet. Often they will walk barefoot and may injure themselves. There are lots of incidences where people may be stand on broken glass or walk on a bindi or injure themselves in walking on hot pavements. And so there's potential, a lot of risks in the environment, and when somebody's walking barefoot, then they will obviously develop or a greater risk of developing those problems.
If they're out there, they've got no transport to get shoes, they just live out in the bush, or they just live out in remote areas and they just have thongs and stuff like that. That's all they wear, is thongs mainly. And then thongs is not really good enough to do the cover work for their feet.
And a lot of times the diabetes is not well controlled, so there may be a difficulty in accessing services to assist with compliance, or the person may not completely understand the importance of taking their medication. So we often see patients who have very, very high blood sugar levels, and that of course puts them at greater incidence of infection and delayed healing.
When you get diabetes, they feel so good, they don't think it's going to be any complications until further down the track. That's when they start getting the complications. They think, oh, I should have done something more. But by the time they realise, it's too late because they can't do nothing. All the damage is already there. So what needs to be is more education on diabetes and the complications.
And with some of the other complications, you act on them. If you don't see well, if diabetes affects your eyes, people can't see, they do something about it. If they have a heart attack, they do something about it. But with feet, when the nerves are affected, they don't hurt. So it's really easy to keep walking around with an ulcer or an infection in your foot and not have to do anything about it. There's not the pain. And there's not the limitations. So people can often keep going for a long time before they become really unwell with a diabetic foot and need to be admitted to hospital. So some recent health department data from 2000 to 2006 showed us the age-specific rate for amputations of 42 times the rate of amputation for knee amputations in Aboriginal people as opposed to non-Aboriginal people, and 27 times the rate of toe or foot amputations for Aboriginal people. So we've got a huge problem right now.
I think obviously when somebody has a leg amputated, they are at a significant disadvantage whether they're Indigenous or not. But maybe some of the more complicating factors are that for that to happen, for not only loss of a whole limb, but partial loss, even partial loss of a foot, a section of a foot, means that you have to take that person away from their community, from their home.
With dialysis and feet amputations or amputations, it's the biggest thing amongst Aboriginal people out in the communities because they can't get the treatment what they need at bush. They've got to come down to the Perth to get all the get all the treatment what they do need.
And then, of course, it's accessing the services that are ongoing, which are required, such as prosthetic and orthotic services for the manufacturer of the limb and for the ongoing fitting and measurement. It means they have to stay in a major city such as Perth or Darwin for a protracted period of time until all of those things are good enough for them to go back to their community. So it has a huge impact in that way. And of course, cost to the health system in transporting patients from remote communities to major cities where these procedures can take place. Then when people are back in their home country, sometimes if they have a problem that develops, maybe the stump shrinks or the access to the support services is in the Kimberley non-existent. We don't have, as far as I'm aware, visiting prosthetists or orthotists that can assist with that. So you're then reliant on things such as video conference or teleconference to try and tap into these expert services and trying to be able to see what's happening to that person while they're walking via video to offer any support or management. Other than that, it means they have to be transported back down to Perth where they would have access to those services. So it's a very difficult situation to manage.
Doctors and nurses, everyone out there can have a role in preventing some of the diabetic foot amputations. The number one thing is every time you see a person with diabetes, take their shoes off, have a look at their feet. Is there any hair? What's the state of the skin? Is it dry? Is it shiny? This certainly tells us something about the blood supply and about the nerves. So the presence of hair, the condition of the skin. We also then look and see if there's any callus or hard skin.
Callus or thickened hard skin commonly occurs in high pressure areas, very commonly under the metatarsal heads of the feet, and those are key areas where ulceration occurs. And so as a GP, you're in a perfect position really to just get that person to remove their shoes and socks and do a quick assessment. If you see any areas of callus, certainly a referral to the podiatry team would then be very appropriate to have that callus debrided and try and offload those areas.
Because sometimes we do debride them and we find there's an ulcer underneath, and if the person's got neuropathy, damage to the nerves, they've got no idea. Okay, so yeah, doctors, nurses out there can actually be debriding the callus to check there's good healthy skin underneath. As long as there's healthy skin underneath and this is just pure pressure areas, sure, podiatry can manage some pressure areas, but if you find a wound, we can keep track of them. The other really high predictor of osteomyelitis or infection that's gone deeper is, does the wound probe to bone? This is a high predictor. If it probes to bone, it's worth a referral or a phone call to one of the head of departments of podiatry in the cities for some more advice.
It's very useful to have a monofilament present as well, so you can do a quick assessment of their neural function or the sensitivity, and to feel for pedal pulses such as the dorsalis pedis pulse or the posterior tibial pulse. Those are quick and simple things that can be done and may help alert to potential future problems.
There's a fantastic form called the Diabetes Assessment of Risk form, available online, and it asks you to check the pulses, to use a monofilament, to identify any lesions, any calluses or corns, things like that.
So the DART assessment tool is a very simple, straightforward checklist, if you like, which looks at aspects such as circulation and the presence or absence of neuropathy, as well as looking at a variety of deformities which somebody may present with, such as previous amputation or very long or ingrown toenails or thickened nails. All of these things can, if not treated or managed properly, can lead to problems later on.
It's a tick box that work on the sheet, tick it, and at the end it helps you decide if they're high or low risk. Low risk people, keep educating them, keep checking them again, but for the high risk people, it's well worthwhile to refer them to a podiatrist for a comprehensive assessment. This is a monofilament. It's to test people's protective sensation, to know if they can actually get that first warning sign from the nerves that something's going on. A lot of people do it in a lot of different ways. The best way to do it is with a forced choice, which means I say, I'm going to count to 2, and I'm either going to press it onto your foot when I say 1 or when I say 2, and you have to choose for me. I always test it on someone's hand first before we do it on their feet, because when you do it on their feet, they should have their eyes closed. So for example, on a hand, I'd go 1, 2, and the person would say 1 because they felt it when I said 1, or 1, 2, the person would say 2. It's when they felt it. And it's really important if we can do this forced choice, because people with diabetes and damage to the nerves, they get a lot of different sensations. Some get burning, some get tingling, some get a feeling like this. So I need to know they're actually feeling my monofilament, my 10-gram monofilament, as opposed to just one of those sensations they get. If people can't feel the monofilament, it means they've lost that protective sensation. It's nerve damage, so there's nothing we can do to bring it back. That's when education is so important. We've just got to then tell people to check their feet every day, to actually use their eyes and their hands to have a look. Because a new pair of shoes, a blister forming, something rubbing, they won't feel it. Something that's gone through the bottom of the shoe or gone into the shoe, they won't feel it. So then we just have to educate them about check your feet every day, to actually turn up your foot and have a look. It doesn't take long, but it saves feet.
Like when I was first diagnosed with diabetes, for instance, I wasn't told to go and see a dietitian. I wasn't told to see a physiotherapist. I wasn't told to go and see a podiatrist to make sure that my health, that I will have diabetes, but I still need all this education. I've never had no education. The only education I had was in the last 4 years since I started working as a health liaison officer. And a lot of Aboriginal people out in the community, they haven't got that education. They don't know how to use a glucometer. So if they haven't got these kind of things, how are they going to look after their diabetes? It's just a complication. They just have their sugar levels high all the time, and that's where the amputation and dialysis come in. And the majority of Aboriginal people I know has got those problems, have got diabetes, and they don't know nothing about them.
And GPs are in a marvellous position really to often provide that education as the primary caregiver usually, or primary healthcare provider that the person with diabetes will go to see. Then the promotion of healthy habits related to foot care is really important, and that could be as simple as getting the person to check their feet on a regular basis when they're washing their feet, to make sure that they're looking for any cuts or bruises, any areas of high pressure which would lead to callus, to cut their toenails straight across rather than digging in down the sides, which can often lead to ingrown toenails and problems of that nature. To use emollients, sort of moisturising creams on areas of dry skin, especially in regions such as the Kimberley during the dry season. We see that people's skin dries out quite considerably. and when they're not wearing footwear or only wearing thongs, this can have quite a big effect on the heels drying and cracking and splitting open. So we try and encourage the use of emollients and moisturisers quite regularly to try and keep the skin in a good texture. So the GP, as I said, is in a perfect position to try and promote those healthy habits, and referral to a podiatrist if necessary, of course. But I think it's good to maximise those opportunities to talk about foot care whenever you can.
I know it's a lot of work for a doctor to follow their care all the way through. Aboriginal health workers come down to Marmaridge and do the full training down here, and they do the DART assessment on clients, so they are pretty confident in that when they go back out into their communities, they are able to do the examination on their feet, just check it out, see if they need any further treatment or more education.
And it is possible. There are international examples of where this has happened. Brazil had the Brazilian Saving Diabetic Foot program. This was really fantastic. It had 3 levels to it, but one of the focuses was at GPs, and that was to ask doctors, nurses, educators, anyone who sees someone with diabetes, to actually take the person's shoes off, have a look at their feet, and then put your hands on their feet. Really have a look and a feel.
Thanks to Leslie Newcomb and Deborah Schoen. And if you'd like to access resources for yourself or for your patients about caring for feet, a great range of resources is available from the Indigenous Diabetic Foot Program section of the Service for Australian Rural and Remote Allied Health website at www.sara.org. Now, don't forget, if you'd like to review this program or any previous program, you can watch them online or download them as a video or audio podcast via the Rural Health West website at www.ruralhealthwest.com.au. We'll be back again on the 1st of September with the program on complementary and alternative medicines. Thanks again to everyone who was part of the program tonight, and thank you for taking the time to join us. I'm Jerry Gannon. Good night.